Hello, it's a great pleasure and honor to talk about light adjustable and modular IOL technology. Here are my financial disclosures. Why adjustable IOL technology? Well, we still have a certain amount of patients with deviation from target refraction, which is especially important in multifocal IOL lens technologies, and we have an increasing number of post-keratorefractive refractive eyes, for example. Well, let's first start about talking about multi-component IOLs. One of them is the so-called Harmoni lens that comes with a basic lens, which is implanted into the bag, and then the optic is implanted into this basic lens. That could be a toric lens or multifocal lens or even monofocal lens. So it can accommodate and can easily be exchanged, for example. And the second one is the Presbyopia lens. That's also basic lens design, and then the optic, the second part, is implanted into this basic design. You can see here in this animation that both the basic optic as well as the optic is implanted into the bag, and then OVD is injected in this interface, facilitating IOL exchange. And the last one is the Juvene from LensGen. It comes as a modular IOL, and the fluid lens then is implanted into this modular IOL, and at accommodation the forces are transduced to the modular IOL, and this, which is attached to the fluid lens that contains silicone oil and is expected to change its anterior curvature, giving accommodation. So this lens consists of a dual optic silicone IOL system with low anterior and posterior capsular opacification. Is stable, and exchange is facilitated. Future options include monofocal toric, drug delivery, or biometric sensors like IOP sensors. So all these multi-component adjustable IOLs offer greater flexibilities, additional options like sensors, drugs, depth of focus, and are a very interesting option in increased chance of greater refractive change like pediatric cataract, progressive cornea pathology, or the use of tamponates in vitreoretinal surgery. Still, information of the stability after opening posterior capsule is lacking. And the second option is the light adjustable lens technologies, which is available as a three-piece foldable silicone IOL with a 6mm optic, 30mm overall diameter. Comes from 10 to 30 diopters with a UV protection and a sub 2.7mm injection, with an improved LDD device in ergonomics and UV irradiance. It allows earlier post-implant adjustments, less lock-ins, a 3-diopter correction for myopia, hyperopia, and an expanded range of astigmatism from 0.5 to 3 diopters, treating astigmatism. Potential drawbacks are time investment, follow-up treatments, and pupil dilation requirements. All of them are, of course, solvable. The new Presbyopia Solutions, individually adjustable mini monovision, new EDOF profiles, and the individual induction of negative asphericity. Here in a prospective multicenter European trial, we were able, even using partial coherence interferometry and latest IOL calculation formulas, in the 20/20 or better group, you can see after adjustment an increase from 33 to 73% uncorrected distance visual acuity in this group. And the European trial results were slightly better than the LAL PMA trials. But down the road, we have seen so many new technologies coming in and going out. Long-term safety, where we now have 12 years of experience. This is my first patient, operated in 2008. Still extremely happy with uncorrected distance visual acuity of 20/20 and 0.63 at near. So in conclusion, multi-component technologies are very promising new options, are interesting for specific indications. The light adjustable and new IOL technology is safe and efficient, offers great options to improve refractive outcome for advanced patient care with a great number and high number of satisfied patients. Thank you so much for your attention.